and it goes laterally. Because the tibial tubercle in nobody's knee is the tibial tubercle located directly under the groove. It's always positioned, if you look at a knee in the axial plane, the tibial tubercle, you can't really see the skyline view here, but it's lateral. You looked at somebody's knee lined up, you look at the center of their kneecap and then find the bump on their knee, it's never directly under their kneecap. It's always a little bit lateral, okay? That's the way we've evolved. And so if you measure the angle by which the line of rectus femoris changes direction at the patella, that's called the Q angle. Now in and of itself, the fact that the Q angle is non-zero means that there's going to be a net lateral force on the patella whenever the quadriceps is activated. It's crummy design. It argues against the theory of intelligent design, frankly, because it's a dumb design. We've evolved that way. It seems to cause problems. The Q angle is affected by static factors, like what are the shape of your bones? Where is your tibial apophysis or tubercle located? What is the shape of your trochlear groove? Some people have shallow grooves, some people have deep ones. Some people have what's called a jockey cap patella or a flat patella. We have osseous variations. And some people are predisposed to patellofemoral issues because the shape of their bones increases the laterally directed force on their patella under normal operating circumstances. But more commonly, people have dynamic misalignment, where the shape of their skeleton is adequate, reasonably normal, but they walk like this, and their feet pronate, and their hips rotate in, and their knees are in valgus, and their Q angle is high, and their patella is getting jacked out laterally with every step that they take. And so the cartilage on the back of their patella is going to wear out by the time they're 25 or 30. They're going to have anterior knee pain. And again, we believe that this is all related to bad dynamic alignment, and you can blame it on their lack of bulky shoes and arch supports, or weakness of their rear foot supinators, but what the literature says is that these people, correlationally speaking, have weakness of abduction and external rotation grooves of the hip. So if you want to measure these angles, any angle, a planar angle, is the intersection of two lines. To define two intersecting lines, you need 3 points. And when you use a goniometer, you put the center of the goniometer on the middle of those 2 points, and then the two arms of the goniometer point at the other 2 points, and you measure the angle. So to measure tibiofemoral valgus, the 3 points involved are the joint centers. The center of the hip joint, the center of the knee joint, and the center of the ankle joint. And if you line those up and they line up perfectly, then this person has 0 degrees of tibiofemoral valgus. If they don't line up perfectly, they maybe have a little valgus angle, like 7 degrees there. Or people can have varus knees. We call those bow legs or knock knees, right? Now that's not dynamic though. Here I am faking it, right? Like if you'd look at me, and if I was standing in your assessment room like this, you'd say, oh, he's got valgus knees. No, I don't. I'm pronated. I have straight knees when I stand in neutral alignment. But dynamically, in loading, I'm capable of exhibiting bad alignment. It doesn't mean that that's the neutral shape of my skeleton when it's unloaded. When I remove all the loads, like if I lie down on the table so I'm not in gravity and gravity's not causing me to do this, when you measure me supine, dead straight, okay? One thing I've got is straight legs. All right, but Q angle is 3 different points. It doesn't come down here to the ankle. It comes to the tibial tubercle. So this is the origin of rectus femoris, the midpoint of the patella, not the midpoint of the tibiofemoral joint, and then the tibial tubercle. Those are different lines, and this is a different angle than whether you've got varus or valgus. They are correlated to each other. People who have valgus knees are highly likely to have a high Q angle. But a Q angle of 10, 12 is normal, even in someone whose knees are perfectly straight. Having said that, just think about it. I've got a muscle attached here, and a muscle attached down here, and the muscle goes off its line. Because the line in between the origin and insertion of rectus femoris does not pass through the center of the patella, it passes laterally to it. So when that muscle attempts to shorten, it's attempting to occupy the straight line, because that's the shortest distance between the 2 points of origin and insertion. In other words, the muscle inherently has a lateral component of force built into it when it's activated. Any muscle that goes around a corner gets pulled in toward the corner. Just like the quadriceps goes around a corner in the sagittal plane, when you pull on the quadriceps, you're pushing the kneecap against the corner that it's going around. Well, the patella is going around a corner in the coronal plane here too, and I'm going to exaggerate it. So when this tries to straighten out, it's trying to straighten that line out, because the rectus femoris muscle is doing this weird thing where it changes direction by 12 degrees at the knee. So any quadriceps activation is attempting to push the kneecap out laterally. There's a coronal plane force. And the more badly aligned you are, the bigger that force is, and the bigger the problems that it will generate. So this shows people with huge brutal Q angles, whatever, okay? Now, I've talked a lot about this, so clearly I think it's important. And I talked a lot about it the first year, but it always disappointed me, in the exams. Whatever, okay, it's first year. This is second or third year now. Wake up. You better get this point or you're going to have a hard time passing the test. Okay? Axial coronal collapse of the lower extremity during closed chain weight-bearing activity causes valgus stress. Because when I go in like this, I'm creating a valgus stress on the knee. It also creates axial rotational stresses. It creates laterally directed coronal stress on the patella. But on the tibiofemoral joint, it creates valgus stress. And it even creates measurable valgus deformation during drop jump landings. Timothy Hewitt showed with high-speed video that you're getting a couple of degrees of valgus deformation when I'm not going to do it because I'll tear my ACL demonstrating it. I've been an idiot before and injured myself showing how not to. So I'm just going to do this in slow motion. But when you land from a jump, if you let your knee go in, you are valgus stressing your knee. And if your knee is valgus stressed in flexion, you're not going to tear your MCL, you're going to tear your ACL. Because your ACL is the primary constraint of valgus movement when the knee is flexed more than 20 degrees. You also create axial rotational stresses that can cause meniscal injury and contribute to ACL injury. And you create this laterally directed force on the patella that is going to cause patellofemoral pain or patellofemoral syndrome, the second most common overuse, so-called overuse problem in the body after low back pain. This is super common stuff. Okay. Any questions about all that biomechanics and alignment jazz? I'll get down off my little biomechanical perch now and we'll talk about some injuries. But I really want you to understand that. I think you've figured that out, that it's important for me to make sure you know that you understand this issue of how bad dynamic alignment of the knee related to hip and foot movement, because the knee doesn't rotate in the axial plane, the knee and the foot do. And axial plane rotations of the knee and the foot cause valgus stress and laterally directed force on the patellofemoral joint. So they affect the knee. These bad movements of the hip and foot. It's all part of the same chain. All right, so we'll move on to mechanisms of injury for acute trauma, and they really can be separated into three categories, if you like. There are collisions. People play rough sports or they accidentally run into each other. These are collisions. So whether the collisions are intentional or unintentional, collisions can bruise tissue. And just a word on that at this point. I guess I'll come back to it in overuse, but not all bruises are created equal. If I take this knee, a poor little kitty riding their tricycle, and they fall down and whack their kneecap on the ground, they may get a little strawberry on the skin. That's if it's a little love tap. They can fracture their femur. The force goes through layers. You have to think in layers. So you're looking at somebody's knee when it was a knee-to-knee collision in a basketball game. They can fracture their patella. They certainly will microfracture, contuse the bone. They can injure going from the skin, the bursa, the tendon, the patella, the cartilage on the back of the patella, the cartilage on the front of the femur itself. The force goes through all those layers. This is true of any contusion. Like I've landed on my hip hard. We'll talk about hip pointers later, falling off my bike on streetcar tracks, and I was worried I'd fractured my acetabulum because you drive the femoral head into the acetabulum and boom goes your pelvis. The force goes through all these layers, okay? So knee-to-knee collisions are not necessarily benign. Fine if they're low speed stuff, but if somebody hits their kneecap hard, you gotta be thinking about what's happening inside the knee joint. Don't worry about the little scrape on the skin. That's what you see. You see bleeding on their skin. Who cares? Collisions can also cause undesirable movement because they create high stresses. So they can cause undesirable translational movement, undesirable valgus or axial rotational movement, because collisions involve high energy and more force than the tissues are designed to absorb. But we are capable of hurting our knees acutely all by ourselves without the benefit of any collision other than a collision with the ground. So if you count the ground, it's still a collision. But what we call deceleration injuries are where you're using the ground to slow yourself down or change directions. So whether it's stopping suddenly or changing direction, a pivot, or landing from a jump, all of those are decelerations. And decelerations cause knee injuries because of forces involved. If you don't maintain alignment properly, the forces can be maldistributed and in the wrong degrees of freedom. Your knee is designed to withstand sagittal plane loading, but not coronal plane or axial plane loading. And if the alignment of your leg when you land or decelerate is such that the reaction forces will create significant coronal or axial moments of force, you're going to rip your knee up. The third type of injury is a slow motion loading. It's called an overpressure injury. Think yoga. I see about 3 or 4 torn medial menisci per year from lotus position in yoga, or even people just, where they think they're stretching their knee and they're, jamming their heel into their butt, whatever, with the lotus position. Again, I don't want to tear my meniscus, but they get themselves folded up, and they're not just in flexion. They're putting overpressure in flexion, but this is creating some axial rotational stress. As I tuck my heel into my groin, I'm turning my tibia at the same time as I'm flexing it and straining my meniscus, and pop goes the meniscus. So it can be slow motion. It could be getting out of a bathtub. Somebody who's deeply flexed as they rise from the bathtub, if they axially rotate on their knee when it's deeply flexed, they're going to tear their meniscus. So one of the issues, I'm going to show you a volleyball injury in a minute, and in the volleyball video you can't really tell how much valgus is involved, because you can get, when you're observing somebody in the coronal plane, this is almost fake valgus. I'm getting some valgus out of it. But notice if I internally rotate my hip and point my foot that way and then flex my knee, you'll see a valgus angle if you're looking at the coronal plane projection. But my knee's not in valgus, now it's just flexed. This guy's not flexed. You can tell because his foot is pointing in that direction, that his knee is going up, okay? And I don't think he's got a 90-degree tibial torsional deformity, unless he's got a spiral fracture. So that's probably a 3-ligament knee to go 90 degrees. You can't go 90 degrees just tearing one ligament. You've got to pop both cruciates and the medial collateral. I've seen one 3-ligament knee in my life. I'll allow myself time to tell one story here. Do I have time? What the hell? Go for it. 2 years out of medical school, I was studying computer science. Don't ask. Okay? I was a professional student. I went back to school, worked part-time as a doctor. A friend of mine was the occupational health physician at Molson's Brewery on Fleet Street. It's a condo now. Molson moved up to the airport, but the brewery used to be down there. And so I would go and work for him when he was on vacation. It was a pretty boring job. You'd sit there and smell like beer because the whole place reeked. I was reading books, whatever. See the odd guy who had a bad back who wanted, whatever. Anyways, workers' comp stuff. And then one day as I'm, flipping through a book, an announcement, emergency, medical emergency, men's locker room. I'm like, holy shit, an actual emergency at Molson's. I grabbed the oxygen tank and a little black bag,